So the learning objectives for this afternoon is to define glomerulonephritis, understand its pathogenesis, differentiate between nephritic and nephrotic patterns, describe key histopathological types of glomerulonephritis, and recognize some clinical presentations and diagnostic findings, and of course, to outline basic management principles. So the definition of glomerulonephritis is it's a group of diseases causing inflammation of the glomeruli, leading to hematuria, proteinuria, and renal dysfunction. So just to orient ourselves, we have to go back to the normal glomerular anatomy and function. So glomerular filtration barrier has 3 different layers. So depending on which area is going to be damaged with your glomerulonephritis, see that the effect or the manifestations of disease will depend on which of these layers has been affected. So number 1, it's the endothelial cells. It's fenestrated typically, and they let small solutes pass, but not cells. Then you have your glomerular basement membrane, or GBM. It is negatively charged and will prevent protein leak. And then you have your podocytes with slit diaphragms. It is a selective barrier for high molecular weight proteins. So on the left side of your screen, you'll see this is your normal glomerulus cell. So you'll see that here you have your endothelial cells. So here it's inside, so again, endothelial. In between, you have your mesothelial cells. This green line is your basement membrane. And surrounding it, you'll see the different foot processes. In your endothelial cell, you also see your fenestrated endothelium. And then, of course, outside, you have your epithelial cells. You'll see that inside the endothelial cell will be your capillary, where your RBCs are located. On the right side, you'll see certain damage or problems that we see in glomerulonephritis. For example, outside, you can see your subepithelial immune complexes deposits, which we often describe as humps. You can have a narrowed capillary lumen compared to the normal. And then that will cause some of the red blood cells to go outside of your glomerulus. At the same time, you can also have a thickened GBM. This is not seen actually in this illustration, but you will see some pictures later. You can also have an increased number of mesangial cells compared to the normal. You might see a couple. Here, you'll see a lot more of them. You can also see some deposits, infiltrates. You'll see the foot process can be fused compared to the normal. The normal, they're separate processes. You see here a few different foot processes are merged together. And then you can see some PMNs and leukocytes inside the capillaries, which we would not normally see. Right. So if we have endocapillary, meaning your endothelial and mesangial injury, that will lead to a presentation where you will see hematuria and RBC CAS. So this is typically seen in patients with nephritic syndromes, such as your post-infectious glomerulonephritis, IgA nephropathy, and also some forms of lupus nephritis. So inflammation will cause swelling of your endothelial cells, narrowing of your capillary loops, and then eventually some rupture of your GBM. The RBCs will then enter the Bowman space, and they will appear as dysmorphic RBCs or RBC CAS in urine. So the reason why is because the opening where the RBCs can pass will be irregularly shaped. That's why the RBCs will have to conform or change their shape in order to pass through these openings. And so this is also why some of us, when we're not sure if the hematuria is because of a glomerular injury or because of other causes, like maybe nephrolithiasis or something else, we'll actually order a urinalysis with RBC morphology. So the morphology will tell us what the shape of the RBCs are. If it's just bleeding from your urinary tract, like from your nephrolithiasis or sorts of similar injury, then the RBCs will appear as normal-looking RBCs. However, if they're coming from the glomerulus, it will become a dysmorphic-looking RBCs. So capillary clogging will also reduce your GFR, and that can lead to your oliguria, fluid retention, and hypertension. So clinical correlation here is that these patients will present with your cola or tea-colored urine. They will have mild to moderate edema and then hypertension. So on the next part here, you'll see what if they have subepithelial or podocyte injury. Then the patients will present with proteinuria and edema. So this is seen in minimal change disease, FSGS, and membranous nephropathy. So your podocyte foot process will become effaced, and there could also be immune complex deposition under the podocytes that will disrupt the charge barrier. So this leads to albumin and other plasma proteins becoming lost in the urine, and that will have you see heavy proteinuria. That means more than 3.5 grams per day. Eventually, there will be a drop in the plasma oncotic pressure, and then the patients will present with a generalized edema. So clinical correlation here is patients will complain of a frothy urine. So the frothy urine, you would normally ask the patients what their urine looks like. It looks like soapy, or yung froth sa taas ng beer. So that's what the normally description of frothy urine. And usually you'll ask them that if you flush the toilet, usually some of the froth will remain. So typically if it's just not really frothy urine, but some bubbles because of heavy urination, it usually does not disappear. Yung frothy does not disappear with some flushing of the toilet bowl. And then they will have periorbital or generalized edema. And then, of course, they can also present with hyperlipidemia. So the third is complement activation and cytokine release. This leads to inflammation and damage of your glomerulus. So you can have the classic or alternative pathway, complement pathways. They can be triggered depending on the antigen-antibody complexes. So you can C3A or C5A, they will recruit neutrophils and monocytes, and they lead to endocapillary proliferation. And then some of your local cytokines, your IL-1, your TNF, or your PDGF, they will stimulate mesangial expansion, and this eventually leads to sclerosis over time. This also explains why an acute glomerulonephritis may eventually evolve into a chronic glomerulonephritis, or what we call our sclerotic or fibrosis stage, with proteinuria and progressive renal injury. So lastly, we have our crescent formation. This leads to rapid loss of function. So severe injury can cause fibrin leakage into your Bowman space. The parietal epithelial cells will proliferate and lead to your crescents that compress the glomerular tuft. And this leads to a rapid decline in GFR within weeks and is the hallmark of your RPGN, or rapidly progressive glomerulonephritis. So clinical correlation here is a rapid rise in creatinine, oliguria, hematuria. If there is hematuria with some pulmonary involvement, this is usually maybe something like we call good pasture syndrome. So this is just an illustration showing the changes. So on letter A is just a normal glomerulus, and you'll see that the damage or the way the crescent forms is there will be some fibrin, some gaps or holes in the GBM because of the glomerular disease, and there is leakage of your macrophages and other infiltrates in this area. Eventually, the infiltrating macrophages will proliferate, and then eventually there will become fibroblasts here, and then that will lead to your fibrocellular crescent formation. Right? So just linking the different mechanisms to the syndromes. So just a quick summary, you'll see your endocapillary inflammation. It's usually represented by your post-infectious GN. The dominant findings are hematuria, RBC CAS, mesangial immune complex, IgA nephropathy, episodic hematuria, subepithelial deposits. It's membranous nephropathy, presents with proteinuria and edema. Your podocyte effacement, it's minimal change disease, nephrotic range proteinuria, and GBM rupture and presence. It could be anti-GBM or RPGN, and its presented finding is a rapid renal failure. Right. So going back, we said that we wanted to know more about the two syndromes. So the two syndromes are nephritic and nephrotic. So nephritic syndrome, the pathophysiologic focus is the inflammatory injury of the glomerular capillary loops. So usually the endothelium plus the GBM. The key clinical features, hematuria, pyuria, proteinuria, but it's usually mild to moderate, so less than 3.5 grams per day. They can have oliguria and elevated creatinine, leading to your decreased GFR. They have mild edema, so mild to moderate, usually just periorbital, but not generalized edema. And then they have hypertension from salt and water retention. So again, we mentioned before, post-infectious GN, IgA, lupus. Your nephrotic syndrome is usually in non-inflammatory podocyte injury or subepithelial immune deposit leading to loss of charge and size selectivity. So key features is proteinuria more than 3.5 grams per day. It's usually selective for albumin. And then you can have hypoalbuminemia at the same time because of that increased loss of albumin in your urine. You will also have generalized edema, or what we call anasarca. You can have hyperlipidemia and lipiduria because of your overall fat bodies. And then patients usually have normal or just mild BP elevation. So representative causes, your minimal change disease, FSGS, membranous nephropathy, and diabetic nephropathy. So just comparing the two syndromes and their features. So you'll see primary sites of injury, your urine appearance, cola-colored RBC cast. Here it's frothy or fatty cast. Proteinuria, less than 3.5 grams. Here nephrotic, it's more than 3.5. Blood pressure typically elevated in nephritic syndrome, normal to low in nephrotic syndrome. Edema is mild in nephritic, severe or generalized in nephrotic. And the main clinical issue for nephritic is usually because of the decline in GFR causing your azotemia, edema, hypertension. For nephrotic, it's the protein loss causing the edema and hypoalbuminemia, and then example diseases. Right. So what are the chronic effects and progression of glomerular disease? So if you have persistent and severe glomerular injury from any GN, they can lead to irreversible structural remodeling and loss of functioning nephrons, culminating in your chronic kidney disease. So the pathologic progression, usually there's persistent glomerular infiltration because of ongoing cytokine and complement activation. You can have your mesangial and endothelial proliferation. Next, you'll have your glomerulosclerosis. So the collapse or obliteration of your capillary loops, accumulation of ECM. Eventually, the glomeruli become hyalinized and non-functional. You can also have at the same time tubular interstitial injury. So you can have tubular atrophy and interstitial fibrosis from ischemia and protein overload, and eventually have arteriolar changes. So you can have hyaline arteriosclerosis and vascular narrowing, causing worsening of the ischemia. So some structural changes in chronic GN. So for the glomerulus, you'll have global sclerosis, thickening of the basement membrane, collapse of some of the loops. For tubular, again, we mentioned atropic tubules. For interstitial, you have fibrosis and chronic inflammatory infiltrates. And vascular, you have atherosclerosis and intimal thickening. So these are the same changes that we might look for in certain diseases or glomerular diseases, which lead us to think that maybe the patient has a chronic condition. Some acute intervention might not be very helpful for some of these patients because the changes have been happening for a long period of time. So depending on sometimes what we see on a biopsy, the management might be different for different patients. So clinical consequences of all of these changes is that we can have progressive decline in GFR from your tubular obstruction due to your interstitial inflammation or fibrosis. You can cause extrinsic compression that results in your glomerulonephrons. You can have interstitial changes, either edema or fibrosis that alter the tubular and vascular architecture and eventually compromise your normal tubular transport. So symptoms would be fatigue, anorexia, nausea, and pruritus, which are some of your uremic symptoms. You can have hypertension if not previously present, because this is due to salt retention and your RAS activation. Patients will complain of edema and have volume overload. Patients will eventually develop anemia because of a decrease in erythropoietin. And then you can have metabolic bone diseases because of your abnormal phosphates, calcium, and vitamin D. I'm not really going to go over this, but these are the different syndromes that are in tabular form from your Harrison's, right? So you'll see that we have different acute nephritic syndromes. So you'll see more or less it's mostly they'll present with hematuria, not so much of proteinuria. Some of them will or will not have vascular injury depending of the type of nephritic syndrome. You have your pulmonary renal syndromes. And then we have our nephrotic syndromes here. Again, you'll see here mostly proteinuria, not much of hematuria or vascular injury. You have your basement membrane syndromes and then your glomerulovascular syndromes. So again, this is just a reminder, just to orient yourselves again to your normal looking glomerulus, because we'll see some illustrations later on. So just so you know which parts we are looking at. So again, first we're going to discuss nephritic syndrome. Same slide as before, just to summarize the key features of your nephritic syndrome. So here we have a case. There's a 7-year-old boy that presents with two weeks after a sore throat with colored urine, mild facial swelling, and an elevated blood pressure of 150/90. So here, the typical mechanism is the immune complex deposits in the subendothelial and subepithelial zones, leading to complement activation, neutrophil infiltration, and then endocapillary inflammation. The capillary wall rupture allows RBCs to leak into the Bowman space, leads to your hematuria and RBC casts, and the swollen glomeruli will reduce GFR, leading to salt and water retention and to that minimal edema and hypertension. So this is acute post-streptococcal GN. So etiology is often after a group A beta hemolytic strep infection, either during on the skin, so impetigo, or more commonly throat infections with a particular M-type strep. So antibiotic therapy does not reduce the occurrence of post-strep GN due to pharyngitis. It usually develops 1 to 3 weeks after the infection. And for impetigo, it usually occurs 2 to 6 weeks after infection. So demographics, usually mostly children 2 to 14 years old. However, in developed countries, it's often seen in elderly patients associated with debilitating conditions. It's more frequent in males, and there is a 40% familial or cohabitant in this incidence. So the classic presentation is an acute nephritic picture with hematuria, pyuria, red blood cell casts, edema, hypertension, and some patients with oliguric renal failure. It may be severe enough to appear like RPGN. So systemic symptoms may include your headache, malaise, anorexia, and flank pain in about 50% of cases. So 5% of children and 20% of adults will have proteinuria in the nephrotic range. So histology, you'll see hypercellularity of your mesangial and endothelial cells, glomerular infiltrates of polymorphonuclear leukocytes, and granular subendothelial immune complex deposits of IgG, IgM, C3, C4, C5, 9, and subepithelial deposits which appear as humps. So this is what we're talking about for acute post-strep GN. However, the humps are something like this. Usually you'll find more of the deposits. That's why they look like humps along the epithelium. So when you do a culture for a strep infection, they are actually inconsistently present in post-strep GN, only between 10 to 70%, depending on the study. But the patients typically will have increased titers of ASO, around 30%, anti-DNase, 70%, or your anti-hyaluronidase antibodies, 40%, that will help confirm the diagnosis. It rarely requires a kidney biopsy, so usually the diagnosis is based on the medical history and presentation of the patient. So treatment is often just supportive, and then you'll give antibiotic treatment for the strep for patients and their cohabitants if it's not yet been given. However, there's usually no role for any immunosuppressive therapy. So prognosis is excellent in children. However, some adults, when they present with post-strep GN, they might have any chronic glomerulonephritis. So next we have your subacute or infective endocarditis associated GN. So it's usually it's an immune complex GN secondary to chronic bacterial infection, often with Staphylococcus aureus or Streptococcus viridans. It's usually in patients who have who've been untreated or who have negative blood cultures, or have right-sided endocarditis. So risk factors would include patients with valvular heart disease, previous IV drug use, patients with hepatitis C, and those who are diabetic. So patients, if you look at their kidneys grossly, they will have subcapsular hemorrhages, or what they call a flea-bitten appearance of the kidney. So pathogenesis, usually you have circulating immune complexes that deposit in the glomeruli, leading to your complement activation and eventually diffuse endocapillary proliferation. So clinical presentation, commonly patients will present with a clinical picture of RPGN, and they will have presence on kidney biopsy. Embolic infarcts or septic abscesses may also be present. So gross or microscopic hematuria, pyuria, and mild proteinuria. Patients can have acute kidney injury or RPGN with rapid loss of renal function. So histology, focal proliferation around foci of necrosis, associated with abundant mesangial, subendothelial, and subepithelial immune deposits of IgG, IgM, and C3. So the diagnosis, usually when you have a patient that presents with a history, usually of endocarditis or some sort of infection, they will have normocytic anemia, elevated ESR, hypocomplementemia, high RF titers, sometimes present of type 3 cryoglobulins, and increase in circulating immune complexes and ANCAs may also be present. So management for this condition is typically the eradication of infection with 4 to 6 weeks of antibiotics, and then immunosuppression is contraindicated until the infection has been eradicated. Right, then the third nephritis here is lupus nephritis. So etiology, it's a common and serious complication of systemic lupus erythematosus. Renal disease is usually present in 30% of patients at diagnosis, and majority of patients with lupus will eventually develop renal abnormalities during the course of their disease. There have also been patients that have been diagnosed with SLE by kidney biopsy. So pathogenesis, you have your anti-DS, it's double-stranded DNA or anti-nuclear antibodies will form your immune complexes. They will deposit in the mesangium and GBM, and they will lead to a complemented mediated inflammation. So clinical presentation, the most common clinical signs of renal disease is proteinuria, but hematuria, hypertension, and varying degrees of renal failure, and active urine sediment with red blood cell counts can also be present. So this is a classification for lupus nephritis. You don't need to memorize it, but I did want to give you an idea of how the disease works. So the classification is from minimal mesangial lupus nephritis up until advanced sclerosing lupus nephritis. So patients can actually jump from one of the different classes to another, except, of course, for the advanced sclerosing lupus nephritis. And also of note is that patients with class 3, class 4, they can occur concurrently with your membranous lupus nephritis. So for class 1, it's minimal mesangial. It's usually only immune deposits that are limited only to the mesangium. Usually on light microscopy, it's normal. So the presentation for the patients, normally they'll have a normal urinalysis and normal renal function. So it's clinically silent at stage 1, class 1. So class 2 is your mesangial proliferative lupus nephritis. So you'll have mesangial hypercellularity and matrix expansion. Patients at this stage or at this classification will often have microscopic hematuria and or mild proteinuria. They will still have normal to near normal renal function. So class 3 is focal lupus nephritis. So the reason why we call it focal is that only 50%, less than 50% of glomeruli will show your endocapillary or extracapillary proliferation. So usually the patients will have mild to moderate nephritic syndrome. They'll have hematuria, RBC CAS, mild proteinuria, increased BP, and normal to moderately reduced GFR. So diffuse, meaning at least 50% of the glomeruli is involved, usually called most severe class, aside from, of course, a class 6, which is a sclerosing. So 3 and 4 are what we call active disease. So for class 4, it's full nephritic syndrome with or without major proteinuria. Often the patients will have low complements, C3 and C4, hypertension, and progressive rise in creatinine. And then class 5 is membranous nephropathy. So membranous, you'll see subepithelial immune deposits with glomerular basement membrane thickening. So this is the classification where the patients will present with nephrotic syndrome. So proteinuria at least 3.5 grams per day, edema, hypoalbuminemia, hyperlipidemia, and then complement at this, if it's class 5 alone, it's usually normal or mildly, only mildly low. And then class 6 is advanced sclerosing. So more than 90% of the nephrons or glomeruli are globally sclerosed. So this is a picture of patients with lupus who have chronic kidney disease and ESRD because of the lupus. They will have small echogenic kidneys on ultrasound and persistent hypertension. So just showing the histologic picture. So class 1, you'll see it's a normal looking glomeruli. In class 2, you'll see there are already some changes. So you'll see hypercellularity, so increase in the number of cells in the mesangium and expansion of the mesangial matrix. So class 3 is your focal nephritis. So only less than 50%. So you'll see the, on light microscopy, you'll see either less or more than 50% of glomeruli. And then less than 50% will have the endocapillary, extracapillary proliferation. On class 4, it's diffuse nephritis, more than 50%. And class 5, of course, you have your membranous nephritis. You'll see your thickened, this is your thickened glomerular basement membrane. So compare it to the other. So here you'll see this is the GBM. It's normal. Here it's very much thickened, and that's your class 5. So back to lupus. So diagnosis, usually we do anti-double-stranded DNA. It's one of the tests that best correlate with the presence of renal disease. You'll also have hypocomplementemia, meaning low C3, C4. It's common with patients with acute lupus nephritis, and declining complement levels will herald a flare. So we do at least perform one kidney biopsy for patients with lupus. However, since the patient's histology or presentation will change from different classifications, so sometimes if the patient starts to present again with worsening disease, then that would be a time when you might request a repeat biopsy. So you'll see that some conditions do not require biopsy at all, like your post-strep GN, but some conditions you might require multiple or repeated biopsies throughout the patient's course. So additionally, for histology, the immunofluorescence will show a full house pattern, meaning the different IgG, IgA, IgM, they're all light up on imaging. So these, they will immunofluoresce with all the different immunoglobulins. And then management, usually class 1 or class 2, you might not need any additional specific management for the glomerulonephritis. For class 3, class 4, they will at least give corticosteroids with or without mycophenolate or cyclophosphamide. Sometimes they also give rituximab for these patients. Class 5, it's steroids plus or minus immunosuppressive. And of course, you treat any hypertension and proteinuria with your ACE inhibitors or ARBs. So patients with any of the above lesions can also, again, transform to another lesion. Hence, patients will often require reevaluation, including your repeat kidney biopsy. So we have your anti-GBM or good pastures disease. So the etiology here is autoantibodies against A3-NCI domain of type 4 collagen in your glomerular basement membrane and your alveolar basement membrane. So this usually occurs in young men in their late 20s or women in their 60s and 70s. So pathogenesis is linear antibody binding, leading to complement activation, eventually to the GBM rupture and crescent formation. So clinical presentation is a rapidly progressive GN with pulmonary hemorrhage, what we call our pulmonary renal syndrome. So younger patients will typically present with hemoptysis, a sudden fall in hemoglobin. They'll have fever, dyspnea, and eventually hematuria. However, for older patients, they might present with the glomerulonephritis only, and hemoptysis might be found only in elderly smokers. So in histology, you'll have, on light microscopy, focal or segmental necrosis with crescents present. And the IF, you'll see linear IgG along the glomerular basement membrane. This is a diagnostic hallmark for good pastures disease. And diagnosis is you have serum anti-GBM antibodies, and you need to confirm by a kidney biopsy. So management is plasma exchange for antibody removal. You can give high-dose corticosteroids with or without cyclophosphamide, and then you can do supportive dialysis if patient has renal failure. So we have another case here. A 21-year-old student develops gross hematuria within 24 hours of an upper respiratory infection. However, the urine clears up in 3 days. So the mechanism here is your IgA immune complexes will deposit in the mesangium, locally activating complement and cytokines. The capillary loops remain largely intact, so filtration only transiently is impaired. Recurrent episodes correspond to mucosal immune activation. And for your mesangial predominant disease, it's self-limited hematuria without heavy protein loss. So this IgA nephropathy, it's the most common cause of primary GN worldwide. There is a male preponderance, peak incidence in the second and third decades of life. There is an increased prevalence in Asia and the Pacific Rim, about 30%, and 20% in Southern Europe. The incidence is much lower in the US. There is a similarity between IgA nephropathy and your Henoch-Schönlein purpura. It's usually clinically distinguished by the prominent systemic symptoms in HSP, a younger age, usually less than 20, preceding infection, and abdominal complaints. So pathogenesis of IgA nephropathy is your IgA immune complex deposition in the mesangium. Presentation, this is the typical or classical presentation, is recurrent episodes of macroscopic hematuria during or immediately following an upper respiratory infection, often accompanied by proteinuria. It's often persistent, asymptomatic microscopic hematuria, and nephrotic range or nephrotic syndrome is very uncommon. However, it can occur. Histology usually have mesangial proliferation and IgA deposits on immunofluorescence. So the IgA deposits is diagnostic for IgA nephropathy. So prognosis, so IgA nephropathy is a benign disease for the majority of patients. However, for about 5 to 30% of patients, who may go into complete remission, with others having hematuria but well-preserved renal function. In the minority of patients who have progressive disease, progression is typically slow, with renal failure seen only in about 25 to 30% of patients over 20 to 25 years. So this is the current mechanism that they think is working for IgA nephropathy, what they call the 4-hit theorem or paradigm. So they say that hit 1 is the production of your galactose-deficient IgA from mucosal surfaces. Hit 2 is a formation of your autoantibodies against your IgA1. And then hit 3 is the formation of your circulating IgG galactose-deficient IgA1 immune complexes that will eventually deposit as immune complexes in the kidneys. That leads to your glomerular inflammation, hyperfiltration, and tubular interstitial response to proteinuria. And then, of course, other conditions. So here you'll see that the different treatments that are being given right now, some of them are still in their clinical trial stage. So for example, your BAFF or APRIL inhibitors, they inhibit your HIT1 and HIT2. Usually what we might give is your systemic corticosteroid therapy. They will inhibit it after or HIT4, where the IgA has already deposited as immune complexes in the kidney. You'll see your SGLT2 inhibitors, your MRAs or ERAs. They are going to act on the effects, right? They're not going to act on what's causing the patient's condition. So you'll see the targeted release budesonide or mycophenolate will act on the B cell priming in your mucosa-associated lymphoid tissue. On the right side, you'll see a schematic from Harrison's of what your IgA nephropathy might look like. So you'll see the mesangial deposits plus an increase in your mesangial cells. Otherwise, the foot process remain intact and there's no other changes. However, on immunofluorescence, you'll see your IgA deposits. So next we have our ANCA-associated small vessel vasculitis. So etiology is these are posse-immune glomerulonephritis that are due to anti-neutrophil cytoplasmic antibodies or your ANCAs. So you have your C ANCA or PR3, which is your granulomatosis with polyangiitis or GPA. You have your P ANCA or your MPO, which is your microscopic polyangiitis, MPA, or your eosinophilic GPA. So pathogens, they have your activated neutrophils, which lead to necrotizing small vessel vasculitis with few or no immune deposit. That's why it's called quasi-immune. There's not much immune deposits. So clinical presentation, depending on which of the three conditions. So your GPA, granulomatosis with polyangiitis, the patients will present with fever, purulent rhinorrhea, nasal ulcers, sinus pain, polyarthritis and arthritis, cough, hemoptysis, shortness of breath, hematuria, and subnephrotic proteinuria. Occasionally, they may be cutaneous purpura and immunonephritis multiplex. Typically, patients might have been exposed to silica dust, or they might have a history of an alpha-1 antitrypsin deficiency. So on X-ray, they'll often reveal nodules and persistent infiltrates, sometimes with cavities. Biopsy of the involved tissue will show a small vessel vasculitis and adjacent non-cassating granuloma. So for your MPA or your microscopic polyangiitis, the presentation might be similar to GPA, except they rarely have any significant lung disease or destructive sinusitis. So for your eosinophilic GPA or your Churg-Strauss, it's a small vessel vasculitis associated with your peripheral eosinophilia, cutaneous purpura, mononeuritis, asthma, and allergic rhinitis. So hyper-gamma globulinemia, elevated levels of serum IgE, or the presence of your rheumatoid factor sometimes accompanies the allergic state. So histology, unlike microscopy, like mentioned, it was a focal necrotizing GN with crescents. So it's quasi-immune, so sparse or absent deposits on IF. And for MPA, without granulomas. For EGPA, absent eosinophils or granulomas. So management here is usually induction of high-dose corticosteroid plus rituximab or cyclophosphamide. They might do plasmapheresis in patients with rapidly progressive renal failure or pulmonary hemorrhage. They need to have a maintenance treatment with azathioprine or methotrexate. And then, of course, you have to also treat the hypertension and monitor the patient for relapse. So remission occurs in about 85 to 90% of patients. However, relapse is very common. So we have your membranous proliferative GN or MPGN. So you have your immune complex MPGN or type 1. It's usually related to patients with chronic infections. So hepatitis B, hepatitis C, endocarditis, fungal and parasitic infections, autoimmune diseases, and monoclonal gammopathies. So type 2 and type 3, they can be idiopathic and or immune globulin-mediated disease. There's usually a dysregulation of the alternative complement pathway. So pathogenesis, you'll have mesangial and endocapillary proliferation with thickened, what they call a double-contoured GBM due to your subendothelial deposits. And about 70% of patients will have hypocomplementemia. So on light microscopy, you'll see lobulated hypercellular glomeruli, or what we call a tram track or double-contoured glomerular basement membrane. And then for electron microscopy, you'll have subendothelial and sometimes intramembranous dense deposits. So here, the tram tracking is not seen in this illustration. However, you'll see the subendothelial deposits. So you'll see that depending on where the deposits are, it tells you or can tell you what kind of GN the patient might have. Aside from that, you'll have a widened mesangial space, mesangial interposition, and then of course you'll see some macrophages and mesangial cells in the mesangium. So next, membranoproliferative. So the previous one is mesangoproliferative. This one is membranoproliferative GN or MPGN. So patients with MPGN will often present with proteinuria, hematuria, and about pyuria, about 30% of patients. Systemic symptoms of fatigue and malaise that are most common in children with type 1 disease, an acute nephritic picture with RPGN, and a speedy deterioration in renal function in up to 25% of patients. And then low serum C3 levels are common. So management here is to treat the underlying infection or cause. You control the BP and the proteinuria with your ACE-ARBs. Immunosuppression in idiopathic or complement-mediated forms. This includes your steroids, rituximab. And prognosis, about 50% of patients with MPGN develop ESRD in 10 years after diagnosis, and 90% have renal insufficiency after 20 years. Nephrotic syndrome, hypertension, and renal insufficiency all predict a poor outcome. Sorry, the previous slide was for membrane, this is for mesangial. So mesangial-proliferative GN, or what we call primary mesangial GN. The etiology could be idiopathic for primary or secondary, usually related to some different infections like your P. falciparum malaria, or it's also related to IgA nephropathy, depending on the histologic findings. So pathogenesis, there's mesangial cell proliferation plus matrix expansion due to immune complex or complement deposition limited to the mesangium. So clinical presentation is a microscopic hematuria, mild proteinuria, occasionally asymptomatic urinary abnormalities. So histology on light microscopy, you can have an expanded mesangium with increased cellularity. On electron microscopy, you'll have a mesangial electron-dense deposit. So management here is just control BP and proteinuria. So more or less the standard across the different glomerulonephritis. You can give supportive medication or treatment by controlling the blood pressure and proteinuria with your RAS inhibition. And then, of course, you treat secondary causes. If it's malaria, then you have to treat the malaria. If it's autoimmune, then you might give steroids. And then you can give corticosteroids for persistent and progressive proteinuria. And now, after we finish the nephritic syndromes, now we're going to the nephrotic syndromes. Again, a summary of the key clinical features for nephrotic syndrome is your nephrotic range proteinuria, hypoalbuminemia, generalized edema, and hyperlipidemia with normal or mild BP elevation. So we have a case here. A 6-year-old child presents with generalized pitting edema and frothy urine. There is no hematuria present, and the patient has normal blood pressure. So here the mechanism is because of circulating or T-cell-derived factors that will cause podocyte foot process effacement. The charge selective barrier is lost and the albumin leaks freely into the urine, causing your heavy proteinuria. There is a fall in your plasma oncotic pressure, which shifts fluid into the interstitium, leading to edema. The liver responds by producing your lipoproteins, leading to your hyperlipidemia. So again, podocyte injury will have a nephrotic syndrome pattern or presentation. So minimal change disease. So the etiology usually is primary or idiopathic. It is the most common cause of nephrotic syndrome in children and only about 10 to 15% in adults. So secondary forms are related to allergies, viral infections, your Hodgkin's lymphoma, intake of your non-steroidal, and then, of course, your lithium. So pathogenesis, immune dysfunction will lead to your T-cell-derived permeability factors targeting your podocytes. The clinical presentation is your sudden onset nephrotic syndrome, massive proteinuria, hypoalbuminemia, edema, hyperlipidemia, lipiduria. And then usually they'll have normal renal function and normal blood pressure in most cases. So histopathology, the reason why it's called minimal change disease, because on light microscopy, the glomeruli will appear normal. On immunofluorescence, there's usually no immune deposits. However, on your electron microscope, you'll see a diffuse podocyte foot process effacement, which is the diagnostic hallmark. So here you'll see, if you remember some of our images before from Harrison's, these are your foot processes. But now you'll see in this illustration, there are no longer any foot processes readily apparent in this illustration. So that's why we say it's an effacement of the foot processes. So diagnosis is often presumptive clinical diagnosis in children. However, biopsy confirmation in adults would be needed because it doesn't occur that frequently in adults. And then you'll often have normal complement levels. So the mainstay of treatment is for steroid treatment. Patients typically will have an excellent response to your steroids. However, some patients might have frequent relapses, so they need to consider other immunosuppressive therapies. So patients will require salt restriction, diuretics for the edema. Again, your ACE inhibitors, ARB, for proteinuria reduction. Prognosis is usually excellent. More than 90% will have complete remission. However, recurrence is common but reversible. So next, another case, we have a 35-year-old patient with obesity and hypertension, and then they present with heavy proteinuria and rising creatinine. So the mechanism here is segmental scarring of some of your glomeruli, eventually leading to podocyte loss and maladaptive hyperfiltration in the remaining nephrons. There is a persistent protein leak leading to tubular injury and then progressive sclerosis. The hypertension may exacerbate the injury, causing a declining renal function. So structural podocyte loss produces both proteinuria and progressive CKD. So this is what we call our focal segmental glomerulosclerosis. So patients might have a primary or idiopathic podocyte injury. Secondary causes include your obesity, your HIV infection, which has a collapsing variant of your FSGS, patients with history of heroin abuse, patients with sickle cell disease, or sometimes as an adaptive response to nephron loss. So pathogenesis is like you have a podocyte injury and detachment leading to segmental scarring of some of your glomeruli. So remember our words, if it's focal, some glomeruli, segmental is a part of each glomeruli. So you'll have maladaptive hyperfiltration that causes further glomerulosclerosis and progressive fibrosis. So the mentioned clinical presentation, proteinuria, often nephrotic range. This is non-selective. And so non-selective meaning it's not only albumin. It could be different other proteins that are leaking through. So you can have microscopic hematuria, hypertension, and rapid progressive renal insufficiency, more common than in your minimal change disease. It's often poorly responsive to steroid therapy. And then secondary forms progress slowly, but are less likely to remit. So this is the illustration on the left side found in your Harrison's. You see that some of the there is some detachment of the cells from the glomerular membrane. You'll see some collapsed capillaries and scarring, and then a proliferation of your subepithelial cells. But you'll see some of the other glomeruli are normal looking. So that's why it's a focal sclerosing glomerulonephritis. So it's most prominent in your corticomedullary junction. So sometimes if you do a kidney biopsy, but you miss the CM junction, you might have a normal appearing kidney biopsy for patients who might have FSGS. So that's why it's important that we work together with our radiologists when we tell them that this is the disease that we're considering, and they need to make sure that we have a sample from the CM junction. So on light microscopy, so you can have focal and segmental sclerosis with or without hyalinosis in the involved glomeruli. So on electron microscope, you'll see a podocyte foot process effacement, which is patchy. So again, I mentioned before, for patients with HIV, they might present with a collapsing variant of FSGS. So diagnosis, a renal biopsy is required. Patients will typically have normal complement levels, and we need to rule out secondary causes for FSGS. So HIV, obesity, hypertension, reflux nephropathy. So management, again, ACE inhibitors, ARBs, to reduce proteinuria and control the blood pressure. Corticosteroids are first line for primary FSGS. However, for non-responders, they might consider other immunosuppressants, including your calcineurin inhibitors or your cyclosporin. So we need to have them avoid any nephrotoxins and then we have to treat the underlying secondary cause. So unfortunately, the prognosis for FSGS, a lot of patients may progress to ESRD. So 40 to 60% of patients within 10 years if they have resistant disease. So here now, next condition is your membranous glomerulonephritis or your membranous nephropathy. So etiology here. So if you see something like just membranous, it's mostly nephrotic presentation. Similar when we talk about even lupus, if they have your membranous classification, then it's usually a nephrotic type of presentation. So etiology is about 25% of cases in adults. Peak incidence is between 30 to 50 years old. There is a male to female preponderance of 2:1. And it's the most common cause of nephrotic syndrome in elderly. So we mentioned before that most common cause in children is MCD. And here, this is the most common nephrotic syndrome in the elderly patients. So primary or idiopathic, about 75% of cases. Patients might have autoantibodies to podocyte PLA2R or HSD7A. So sometimes we can actually just do this PLA2R testing. And we already know the patient has membranous glomerulonephritis without a need for biopsy. So for secondary causes, they can be related to autoimmune diseases like your SLE class 5. You have infections, hepatitis B, hepatitis C, syphilis, malaria, different treatments like NSAIDs, penicillamine gold, and then patients with malignancies of the lung, colon, or breast can present with your membranous GN. So pathogenesis, usually in situ, immune complex formation and complement activation, your C5b, 9 MAC at the subepithelial surface. There's often damage to podocytes, leading to your increased permeability to plasma proteins and eventually nephrotic syndrome. So clinical presentation, again, predominantly nephrotic range proteinuria, that's non-selective, edema, hypoalbuminemia, hyperlipidemia, often insidious in onset. You can have microscopic hematuria, about 20% of cases, and they may be associated with thromboembolic events, especially renal vein thrombosis. So most of your nephrotic syndromes can present with your thromboembolic events. However, it's most often seen in patients with membranous GN. So it's something that you have to counsel your patients about if they're diagnosed with membranous GN, about the risk of your thromboembolic events. So often normal kidney function initially, however, 30 to 40% will progress to CKD over years. So here on the left side, you'll see is the illustration in your Harrison's about your membranous GN. You can have subepithelial deposits and their foot process fusion or effacement. And so histopathology on light microscopy, you'll have a uniform GBM thickening. So it should be this. It's not really apparent in illustration, but the GBM is normally seen as thickened. So these are the spikes or the deposits that will be seen on silver stain. So on immunofluorescence, you can have granular IgG and C3 along the capillary loops. And on electron microscopy, you'll see the subepithelial electron dense deposits with intervening spikes. So diagnosis, if you have your PLA2R antibody positive, it's very highly specific for membranous GN, and you can have normal complement levels. So management is typically conservative, ACE-ARB plus diuretics with or without statins, and then only to use immunosuppression if the patient has persistent nephrotic syndrome or declining GFR. If it's because of secondary causes, of course, we need to treat the secondary cause. So next is you have your diabetic nephropathy or diabetic glomerulosclerosis. So chronic hyperglycemia and type 1 or type 2 diabetes leading to structural and functional glomerular injury. So typically when we have type 1 diabetic patients, they might not present with any nephropathy on diagnosis. But for type 2 diabetics, because patients typically will have this disease for a while, at least maybe 5 years that they don't have, they're not aware that they have diabetes. Sometimes by the time that we diagnose these patients, the patient might already have diabetic nephropathy because they have a poor glucose control for a number of years before diagnosis. So pathogenesis, typically you will have non-enzymatic glycosylation of your GBM proteins, which become thickened, a leaky basement membrane, the mesangial expansion from your glycosylated matrix deposition, glomerular hyperfiltration, and hypertension, which can accelerate the injury. And then you can have your Kimmel-style Wilson nodules or nodular mesangial sclerosis, which may appear late. And eventually you'll have glomerulosclerosis and tubular interstitial fibrosis, which will lead to your chronic kidney disease. Clinical presentation, usually at stage 1, the patients might only have hyperfiltration, meaning renal enlargement, increased GFR. Stage 2, the patients might be seen with microalbuminuria, so about 30 to 300 milligrams per day. At stage 3, they'll have overt nephropathy and then macroalbuminuria, meaning more than 300 milligrams per day of protein or albumin loss in the urine. At stage 4, you'll have progressive proteinuria, hypertension, and declining GFR. And stage 5, end-stage renal disease. Usually when we examine their urinalysis, it's a bland sediment, meaning we don't really find anything else aside from the albuminuria. There's usually no RBC, WBC, or any other casts that are seen in the urine sediment. So on histopathology, you have, on light microscopy, diffuse mesangial expansion, GBM thickening, Kimmel-style Wilson nodules, and then on electron microscope, you'll have thickened GBM. So diagnosis, of course, is based on the clinical history of having diabetes for a number of years. And then usually you'll see persistent albuminuria confirmed on at least 2 different occasions for at least 3 months. Patients who have diabetic retinopathy will support a diagnosis of diabetic nephropathy because they usually occur together. So once a patient, when they see an ophthalmologist, they become diagnosed with retinopathy, chances are they already also have diabetic nephropathy. Both are small vessel complications of your diabetes mellitus. So you also need to exclude other concomitant glomerulonephritis should the patient have hematuria, rapid decline in their GFR, or active sediment. So there are occasions when a patient will have 2 GNs occurring at the same time. It's not that frequent, however, it can happen. And that's why it's important if the patient's presentation is atypical that we have to think of maybe there's something else that's happening in the patient. And we don't just say that this patient only has diabetes as the main cause of their kidney disease. So management will often include a strict glycemic control. We want an HbA1c of less than 7. Again, ACE inhibitors or ARB to reduce your intraglomerular pressure plus proteinuria. Your blood pressure target should be less than 130/80. Dietary protein and salt moderation. Patients can be given your SGLT2 inhibitors or GLP-1 agonists as a means of renal protection. And then we also, of course, have to manage the patient's dyslipidemia and cardiovascular risks. So comparing this diabetic nephropathy to your membranous nephropathy. So membranous nephropathy is immune-mediated and potentially reversible. However, your diabetic nephropathy is metabolic and progressive unless you have glycemic and hemodynamic control that's optimized for that patient. We have then a number of your glomerular deposition diseases. So these are typically your plasma cell dyscrasias that produce excess light chain immunoglobulin that lead to the formation of glomerular and tubular deposits that can cause heavy proteinuria and renal failure. The same is true for the accumulation of your serum amyloid A protein fragments that are seen in several inflammatory diseases. So the 3 examples here are their light chain deposition disease. So light chain deposits are not fibril and do not stain with Congo red, but they are easily detected with anti-light chain antibody. You have your monoclonal plasma cell disorders. This is typically your multiple myeloma. Waldenstrom's macroglobulinemia or lymphoma may be present, as well as heart, liver, and pulmonary involvement. The monoclonal proteins may be found with serum electrophoresis or with serum-free light chain analysis. You can also have your renal amyloidosis. So amyloid infiltrates the liver, heart, peripheral nerves, carpal tunnel, upper pharynx, and kidney, producing restrictive cardiomyopathy, hepatomegaly, macroglossia, and heavy proteinuria, sometimes associated with renal vein thrombosis. So for amyloid, it will stain with Congo red. And then we're moving on to your Alport syndrome. So Alport syndrome, it's a genetic defect in your type 4 collagen in your GBM. So the inheritance pattern is often X-linked in 80% of cases of the 12-4A5 mutation. It's autosomal recessive or dominant. COL4A3A4, it's less common. So type 4 collagen is also present in the cochlea and ocular lens, explaining the extrarenal finding. So the pathogenesis is defective synthesis of your GBM collagen, leading to structurally unstable and leaky basement membrane. Your thin GBM, which will thicken over time and eventually will split, causing what we call lamellation from repeated injury and repair. And this leads to chronic glomerulosclerosis and renal failure. So presentation of patients with Alport syndrome is hematuria, sometimes microscopic, sometimes gross hematuria from childhood. Proteinuria will develop later and may eventually reach a nephrotic range proteinuria. Patients will have sensory neural hearing loss, usually very high frequency sounds. They can have ocular abnormalities, so anterior lenticonus or retinal flex. And then they will have progressive decline in their renal function, sometimes ESRD in adolescence or in adulthood. So histopathology, you'll have a regular GBM thickening and thinning and a basket weave lamellation pattern, and that's diagnostic for your Alport syndrome. So diagnosis, you'll have a family history of hematuria, deafness, or renal failure. They can have genetic testing for your COL4A3A5 mutation that will confirm the diagnosis. And eventually, patients also are recommended to have any hearing and ophthalmologic evaluation because even if they don't have it at presentation, they might develop these conditions later. So there's no specific cure for Alport syndrome. Patients are given your RAS inhibition to reduce proteinuria and to slow renal decline. Supportive treatment by controlling your blood pressure, treating edema, asking the patients to avoid nephrotoxins. Eventually, the patients might need renal compensation for your end-stage renal disease. However, they can have anti-glomerular antibodies that may rarely cause a recurrence of the disease. And of course, you need to have genetic counseling for affected families because they're not typically affect just one member of the family, but multiple members of the family. We also have your thin basement membrane disease. So it is a persistent, intermittent, asymptomatic, usually microscopic hematuria and rarely microscopic hematuria with flank pain. It's not typically associated with proteinuria, hypertension, or loss of renal function or extrarenal disease. It's usually familiar autosomal dominant as compared to Alport syndrome, which is X-linked. Here, it's a familial autosomal dominant disease. So we have also your nail patella syndrome. Patients often develop iliac horns on the pelvis and dysplasia of the dorsal limbs involving the patella, elbows, and nails, and variably associated with neural sensory hearing impairment, glaucoma, and abnormalities of GBM and podocytes, leading to hematuria, proteinuria, and FSGS. Again, this is also a familial autosomal dominant, similar to your thin basement membrane disease. And then we also have your hypertensive nephrosclerosis. So these are patients who have pre-existing history of hypertension. So long-standing or chronic systemic hypertension will lead to long-standing injury to renal arterioles and glomeruli. So you can have two different forms of your hypertensive nephrosclerosis. You can have the benign form. So that means a patient with a long history of hypertension, they have chronically elevated blood pressure. It leads to your arteriolar hyaline deposition and eventually luminal narrowing, ischemia, and glomerulosclerosis. You can also have a malignant form, which is a endothelial damage with fibrinoid necrosis and hyperplastic, what we call onion skin arteriolitis, and the patient will have an abrupt GFR fall. So clinical presentation, this is often insidious. Patients are typically asymptomatic very early or even until late in their disease. They can have mild proteinuria, only less than 1 gram per day. Sometimes some patients will have microscopic hematuria, but this is only found occasionally. The patients will eventually present with a gradual rise in their serum creatinine and eventually reduce GFR over the course of years. On imaging, they'll have small shrunken kidneys. And in advanced disease, they can have hypertensive rapidopathy. They might have left ventricular heart enlargement. Patients might present with stroke or heart failure. For patients with malignant disease, they will have rapidly rising blood pressure, more than 180 to over 120. They can present with encephalopathy and acute renal failure. So histopathology for benign, you can have hyaline arteriosclerosis, intimal thickening of your small arteries. You can also have global glomerulosclerosis, tubular atrophy, and interstitial fibrosis eventually in patients who have longstanding hypertensive disease. For malignant, you'll see, unlike microscopy, your fibrinoid necrosis of arterioles, your onion skin hyperplasia of your vessel intima. So diagnosis is usually made based on your history of chronic hypertension with a slowly progressive renal insufficiency for your benign hypertension. However, for malignant, you can have patients with rapidly progressing renal insufficiency. So usually kidney biopsy is not required for these patients. Urinalysis will often show a bland or minimal protein on urinalysis. So management would be to aggressively control the patient's blood pressure as the cornerstone of therapy. Again, your ACE inhibitors or ARB are preferred because they reduce your intraglomerular pressure. You want to manage patients' cardiovascular risk factors. It includes giving your statins, any glucose control if they had concomitant diabetes, lifestyle modification, smoking cessation. For a malignant hypertension, of course, you need immediate IV antihypertensive therapy like your nicardipine or labetalol to rapidly control the patient's blood pressure. These are other conditions mentioned in your Harrison's that includes your cholesterol emboli, your sickle cell nephropathy, and your thrombotic microangiopathies or TMA. So that includes your HUS TTP and malignant hypertension, drug-induced conditions. So just a summary table showing the etiology and trigger. So cholesterol emboli are usually because of your cholesterol crystal embolization to small renal arteries, which often occur after the patient has a vascular procedure. So that includes angiographies or surgeries, or some patients might experience a spontaneous plaque rupture. So the mechanism of injury is often the cholesterol plaques from the aorta. They lodge in the renal arterioles, causing occlusion and ischemic inflammation. So clinical features, subacute or acute renal failure over days to weeks after a procedure. They might present with livido reticularis, blue toes, or eosinophilia. So key histopathology is needle-shaped clefts in arterioles with foreign body giant cells or cortical infarcts. So management is supportive. You want to avoid anticoagulants after any active embolization. And of course, we need to control atherosclerotic risk factors for that patient. So for sickle cell, patient with sickle cell hemoglobin, they might have vaso-occlusion under states where they have hypoxia or acidosis. So pathogenesis is recurrent microinfarction of the vasa recta, leads to papillary necrosis, medullary ischemia, and glomerular hypertrophy. So patients will have hematuria, hypocynuria, meaning the inability to concentrate the urine. They might have proteinuria and eventually progressing CKD. So key histopathology is glomerular hypertrophy, focal segmental sclerosis, and interstitial fibrosis. Management is to maintain hydration, avoid hypoxia. Sometimes they give hydroxyurea as part of management for the sickle cell, and then ACE inhibitor ARB for proteinuria. So for your TMAs, typically it's because of endothelial injury leading to platelet activation and microthrombosis. So pathogenesis, microvascular occlusion leads to ischemic glomerular damage with or without hemolysis. So your clinical fixtures for your microangiopathic hemolytic anemia, you might have increased LDH, cystocytes, and then might have thrombocytopenia, acute kidney injury. Sometimes patients will have neurologic signs and symptoms, especially for TTP, or GI symptoms for HUS. So key histopathology, fibrin, thrombi in glomerular capillaries and arterioles. You can have endothelial swelling, and you can have also your double contoured glomerular basement membranes. So you want to treat the underlying cause. For if a patient has TTP, you might give a plasma exchange. Patients with atypical HUS, you can give eculizumab. And of course, you have to give BP control and stop any offending drugs that might be causing the patient's condition. right? So in summary, so all glomerular diseases reflect injury to one or more of the glomerular components, either the endothelium, the GBM, or the podocytes, by either immune, metabolic, genetic, or hemodynamic mechanisms. So again, the anatomic site of injury determines whether the presentation is nephritic, nephrotic, or mixed. So you'll see as a summary here, the different patterns or mechanisms. So you have inflammatory, podocytopathy, immune complex or complement mediated, systemic, secondary, or hereditary structural. So key pathologic site for nephritic is endothelial or GBM injury. We mentioned the different representative disorders like your post-infectious GN, your IgA nephropathy, and your lupus nephritis class 3 or 4, and their RPGN. Typical picture is hematuria with or without RBC CAS, mild proteinuria, hypertension, and a decrease in your GFR. So podocytopathy or nephrotic syndrome. So with podocyte injury and subepithelial deposits, you can have your minimal change disease, FSGS, membranous GN, diabetic nephropathy. So again, it's heavy proteinuria, edema, hypoalbuminemia, and then hyperlipidemia. You have your immune complex or complement mediated, that the key pathologic site is your mesangial and subendothelial areas or regions. Representative disease would be your lupus nephritis, MPGN, and infection-related GN. So typical pictures is mixed nephritic nephrotic syndrome, and the patients will typically present with low complements. So systemic or secondary, so it could be hemodynamic or metabolic. So here you have your hypertensive nephrosclerosis, your amyloidosis, your myeloma, vasculitic GNs, so proteinuria with or without renal insufficiency, and then the patient will have systemic features. So hereditary or structural, that's your collagen 4 or GBM defects, or your Alport syndrome, your different basement membrane syndromes like your thin basement membrane disease. And then you'll have microscopic hematuria with or without hearing or ocular changes, depending on which specific type of basement membrane disease it is. So common endpoints, they can have eventually glomerulosclerosis, interstitial fibrosis, tubular atrophy, and that leads to your progressive CKD, which is the final common pathway for untreated or severe GN. Principles of management, you want to identify and treat the underlying cause. So that's why part of the diagnosis or diagnostics that we order for patients presenting with either hematuria or proteinuria is that we do hepatitis screening and other things to make sure that we're not missing out on other potential underlying causes, causing only a secondary and not a primary GN. So we want to make sure we rule out infection, autoimmune disease, metabolic or genetic disease. We want to control proteinuria and blood pressure. ACE inhibitors and ARB are our cornerstones of therapy. And then immunosuppression when inflammatory or autoimmunity dominates the picture. We want to monitor the patient's renal function and look out for any systemic complications. And of course, early referral to nephrology for progressive or complex disease. So glomerular diseases often share overlapping manifestations, and understanding the underlying mechanism will explain the patient's presentation and direct you to therapy to prevent irreversible renal scarring. So looking back again, these were our learning objectives, and I hope that you were able to learn and meet our learning objectives for today. That was the last slide. I don't know if you have any questions from the group. I will send the slide to the department, and if you need a copy, then you can request from the department. Okay. Thanks, everyone. Have a good rest of your day.
Thank you po, Doc.
Okay, thank you.
Recording stop.